of COPD. So with that, I'm going to come to the definition. COPD is a common, preventable, and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation. Now, remember that unlike asthma, which we have talked previously, the obstruction, airway obstruction is reversible there. With the treatment, you can completely reverse the symptoms as well as the airflow limitation. So patient can have, in between the attacks, can have a perfectly normal life. But in COPD, this cannot happen. So this is one of the main difference between asthma and COPD, that there is this symptoms are going, once COPD is established, the symptoms are going to be persistent, and there will be a persistent airflow limitation also. The cause is due to alveolar and airway damage caused by inhalation of noxious particle and gases. So that's why it is called as a preventable disease. If you avoid damaging your airways and your lungs, you will not get COPD. So as I said to you, COPD is a leading cause of morbidity and mortality, and at the moment it is the third leading cause of death. The burden of COPD, as projected, it's going to be increasing further in the due course of time. And in any country, COPD is associated with significant economical burden on any healthcare system. So what about the risk factor? The major risk factors are cigarette smoking. Then in our setup, environmental tobacco smoke, number third, which has been shown, is also equally important, because a lot of people here use biomass fuel. The fourth one, outdoor pollution, is also very important in the third world countries like Pakistan, because we have been using biomass, and again on our streets there are a lot of air pollution, and that is also contributory. Similarly, environmental tobacco, that is the passive smoking, has also been a contribution. And occupational, people are working in industry occupations without having proper protective gears. So anybody who has got genetic predisposition, who have frequent chest infection in the childhood, belongs to the lower socioeconomical status, they are the ones which are more likely or more prone to develop COPD if they are being exposed to cigarette smoke, environmental smoke, or occupational smoke. So these are the main reason for that. Now, what happens when you inhale these noxious particles or the gases? Then along with those factors, that is genetic predisposition, belonging from a lower socioeconomical status, right? These are called host factors. This tends to cause lung injury or lung inflammation. Now, there are always protective mechanism in your body, which whenever there is a breakdown, they tend to repair those breakdowns. And these are anti-protease. The breakdown is because of the enzymes, activation of the enzyme called protease. And then there is an anti-protease which try to prevent the damage caused by these enzymes. That is basically catabolic enzymes causes damage to the cell proteins. Similarly, because of the inflammation and because of the metabolic stress, there is a lot of oxidative stress, that is free radicals are being produced in the cell. Then we know that there are a lot of antitoxin, antioxidant, which are also in the body. So there is a balance between the destructive forces and constructive forces. The destructive forces is oxidative stress and activation of the enzyme called protease. These are responsible for causing damage to the airways and to the alveoli. But the protective mechanism, if there is anti-protease and antioxidant, which we tend to take in our diet, they tend to repair those things. But what happens when you inhale these noxious agent and the gases in a large amount? You overcome these protective mechanism, and therefore the destruction take place, and the person develops COPD. So basically, it is the airway inflammation leading to the fibrosis, mucus plugging, and this causes resistance to the airflow. And at the same time, there is alveolar damage. which causes loss of elasticity of the lung, and this all leads to airflow limitation or obstruction. Now, where do we get the evidence? Smoking is considered to be the main culprit agent, or smoke. Now, where did we get the evidence? Evidence this was came basically from a study which was done. It was a prospective study in UK, where all the doctors and their smoking habits were recorded, and what it shows. I mean, it is still going on, and the cause of death has been certain. And this was done by two great epidemiologists, Doll and Peter, and they proved that those doctors who were tend to smoking more are more likely to die from COPD, and those who are not smoking at all like this, I mean, the chances of them dying from COPD was very little. Even if you give up smoking, you don't come to that level of non-smoker, so still you have a higher chance of smoke of death because of the COPD, but relatively less than those who are currently smoking. And again, it shows that the more you smoke, like for instance, the blue bar is of those who are smoking more than 25 a day, they are more likely to die. But even a small amount of cigarette is responsible for increasing the chances of death from COPD. Now, this has also been proven by the different studies and time that children who are being exposed to parental smoking less tends to get frequent chest infections and ear infections. And if you have infections during your childhood, chest infection more in your childhood, then you are more likely to develop chronic bronchitis or COPD in later years of the life. Basically, COPD is a term which encompasses two diseases which is little different from each other, that is emphysema and chronic bronchitis. But this is usually an arbitrary type of differentiation, whether you have a predominantly CO, predominantly chronic bronchitis or emphysema, because the two diseases may behave a little different clinically, but majority of the patients will have an overlap of emphysema and chronic bronchitis. So what is the definition of the chronic bronchitis? Basically, if you have cough for two consecutive years for more than 3 months, this is called as chronic bronchitis. Along now, it is included that you should have airway obstruction with that. What is an emphysema? Abnormal and pulmonary enlargement of air spaces distal to the terminal bronchiole, as it has been shown here. These are alveoli. When they swell up, this is called emphysema, and emphysema results in loss of elasticity of the lung. So if you separate these two things, chronic bronchitis and emphysema, you will have two different types of patients. The one which have got predominantly chronic bronchitis, you will be calling them as a blue blotter. Why? Because these are the ones who will have more cough and phlegm production. They are the one which they will have cyanosis, they will develop pulmonary hypertension, cor pulmonale, and that's why they become edematous, and they are called blue blotters. And basically, they don't appear to be very short of breath. On the contrary, the respiratory center of pink puffers, that other extreme, that is emphysema, that tends to be very active. Whenever, I mean, they respond to low oxygen markedly. So these patients are most of the time breathless, and they will have a classical pursing of the lips, right, indrawing of the costal cartilages, intercostal muscles, then indrawing of the supraclavicular foci, and similarly suprasternal notch. So these are usually thin, lean, breathless, pursing of the lips. These are characteristic of them, and they will be breathless all the time, and that's why they appear to be more pink as compared to blue. They will maintain their oxygen level because of the overbreathing till the very late stages of the disease. They do not develop chronic pulmonary hypertension so early in the course of the disease, and that's why they don't have cor pulmonale and edemas. So these are the two extremities, but in majority of people, we will have combination of these two things. So this is how, I mean, how we diagnose COPD. This is important. Now, clinical diagnosis should be considered in any patient who has got cough, dyspnea, sputum production, with exposure to those factors which predisposes you to develop COPD, like smoking, like use of biomass fuel for cooking, working in a very dusty atmosphere. So these is required along with the presence of symptoms. And the third thing is that you have to perform a spirometry for the confirmation, and it is usually done after giving a bronchodilators. You check FEV1 and a FVC ratio. If it is less than 70%, you confirm that there is an airflow limitation along with the upper two findings, that is sputum production, cough, shortness of breath, and exposure to the risk factor. You confirm that this patient has got COPD. So in nutshell, symptoms, exposure history, spirometry, you make a diagnosis of that. Without that, you cannot make a COPD diagnosis. So as I mentioned to you, that for spirometry, the value of ratio of FEV1 FVC should be less than 70%. This is how, I mean, this is an old instrument in JPMC. This is how we used to do spirometry. Now we have got modern digital machines. So this is what you do is take a deep breath in to the maximum and blow in this machine as hard, as fast as you can, and keep on blowing till the end, till you have completely emptied your vital capacity. So what happens is that this sort of a graph is being produced. Now, normally, the normal person will be able to expire 80% of his vital capacity in first second. So this is called FEV1, force expiratory volume in 1 second. So usually almost 80% of this, your vital capacity is being expelled out in the first second. But in patient of COPD, because of the AL4 limitations, they will not be able to expire. So FEV1 will be far less than what is predicted for that particular person, depending upon his height, gender, and his age. So FEV1 will be low, and similarly FVC. FVC is the one which you record at the expiration, which you record the amount of volume which has been expired in 6 seconds. So in 6 seconds, that is also reduced, but little bit less. This is normal FVC, and this is a lower FVC in a patient who have got COPD. So if you take a ratio, I mean, the ratio is going to be less than 70%. So if it is less than 70%, there it is 0.56%, and less than 50, around 50%. So this person has got COPD. So the ratio between FEV1 and FVC is lower than 70%. This confirms that there is an airflow limitation. And if it does not reverse with giving bronchodilators, this is, or it is reversing partly, this confirm. Unlike asthma, where there is a complete reversibility, here there will be a partial reversibility. So first thing is the symptoms. Then these are the, as mentioned to you, these are the main symptoms of COPD, that is dyspnea, cough, and sputum production. Then assessing the severity of the symptoms, there are various tools to assess how breathless your patient is, and this is called CAT scoring, COPD assessment score test, or MRC, British Medical Research Council breathless score, and similarly clinical COPD questionnaire. So these are questionnaire-based assessment about the symptoms of COPD. For instance, CAT is the scoring system which is most commonly used. It has got 8 items and measure the health status impairment in patient with COPD. So it also take into account the other symptoms, but MRC score, that is breathlessness score, which is designed by the British Research Council. This is also very commonly used. And then there are other questionnaire also. So what is MRC scale of breathlessness? Grade 0 is when you get breathless on a strenuous exercise. Grade 1, when short of breath in walking fast or going uphill. Grade 2, slower walking. You have to stop when you are walking at your own pace on the level surface. I stop for breath after taking about 100. This is grade 3. And grade 4 is that I'm too breathless to leave the house. That is, you are breathless even on your routine daily activities at home. So this is how we assess the shortness of breath. Then how significant is the airflow limitation, which indicates that whether the person has got COPD mild, moderate, severe, or very severe, depends upon the FEV1. If FEV1 is the less than 80% of the predicted, it is called mild. If it is between 50 to 79, it is called moderate, and similarly severe. So depending upon your FEV1, if it is less than 30% of the predicted, it is considered to be very severe COPD. Then it is also important to see the risk of exacerbation in these patients. The risk of exacerbation is dependent on two factors, depending upon how many exacerbation you had in the last year and what is the level of airway obstruction. So if you have got more than two acute exacerbation of COPD in the last year, it is more likely that you will have similar two or more exacerbation during this year also. So previous year can easily predict the number of exacerbation in the current year. Similarly, FEV1, if it is less than 50, this is an indicator of increase. The lower the FEV1, the higher is the chances of exacerbation. Why do we have to assess these acute exacerbation? Because anybody who comes with recurrent exacerbation, they tend to deteriorate rapidly. So we have to address them and give them more treatment so that we don't have this recurrent exacerbation. Therefore, in management of COPD, we do not rely on only one thing, either it is FEV1, either it's a symptom score or number of exacerbations. So they are all grouped together to determine what sort of a treatment are we going to offer. And on that basis, taking these three things into consideration, we divide them into group A, B, C, and D. So what is A group? In which type of patient will be included in group A? Those who have got a MRC score of 0 to 1, that is, they are very mildly breathless. CAT score is less than 10. So they are mild cases of, it should be mild cases of COPD. Similarly, group B, they will be more breathless, more symptoms, but they will not have increased exacerbation. So in exacerbation comes on this axis. So group C, more symptoms, less symptoms, but increased risk of exacerbation, that is greater than 2. Here, more symptoms and more exacerbation greater than 2. So on these grounds, we decide whether the patient of COPD who we have diagnosed, whether it belongs to group A, group B, group C, or group D, and the treatment is according to these things. So for instance, group A, as I mentioned to you, will be the one who have got low risk of exacerbation, less than 2, like it has been shown, and low risk of exacerbation and less symptoms. So they will be, and if you see the FEV1, they will have a mild airway obstruction. All right. So less than 1 exacerbation, MRC score less than that, this is less than 8. So similarly, patient D, high risk of exacerbation, more symptoms with significant or less than 30% of FEV1. So three things have to be taken into consideration when we are grouping that. That is, like it is shown, exacerbation risk, FEV1, and the breathlessness score. So taking all these three, we divide them into 3. Now, in group 1, I mean, they are the milder cases. We usually tend to give them short-acting muscarinic agent like ipratropium bromide as per required basis, or we can give them short-acting bronchodilators like salbutamol as per required basis. So this is the usual treatment for these patients because they are mild whenever they have symptoms, but they should all be encouraged to give up smoking, or if they are working in a dusty atmosphere, they should not be doing that because the COPD is now established. Although their symptom is mild, risk of exacerbation is very little. Their FEV1 is also not significantly impaired. So, but if they continue to smoke, this is going to rapidly progress. So group B, they are giving long-acting muscarinic agent like tiotropium or long-acting beta-2 agonists like formoterol or salmeterol. So these are the drugs which are being given. But in group C, where there is although the symptoms are low, although the FEV1 is not bad, but they have increased risk of exacerbation, more than 2 exacerbation. So we have to combine inhaled corticosteroid with long-acting beta-2 agonist, or we can give alone long-acting anti-muscarinic agent, that is tiotropium. In group D, definitely all patients will be receiving inhaled corticosteroid because they are the ones which are more likely to develop exacerbation. So again, this is the same thing which is being shown. So what treatment has to be offered to which patients? So all these patients should be treated with inhaler, as mentioned in an asthma lecture, that for chest diseases, it's much better that we should use the airway for delivering the drugs directly into the airways. It is also as important that there are a lot of, these patients are being associated with comorbidities because COPD tend to occur in the later stages of the life. So a lot of these patients have got cardiovascular diseases, osteoporosis, recurrent chest infection. Because of the limitation in their activities, they can get anxiety and depression. Diabetes is also very common. And secondly, lung cancer is also very important. So all these comorbidities along with the management should also be addressed. So because these two conditions are very overlapping as far as the symptomatology is concerned. So the main difference is that COPD usually occur in the midlife, because you need a prolonged exposure to the dust or to the cigarette smoking before you develop a COPD. Unlike asthma, usually start in the early life, in the early infancy. Although when the patients reach to the adolescence life, majority of these patients may overgrow their asthma, but later on in the life it may come back again. So it goes into a state of remission, it come back again. So a lot of these people will say that as a child they had issues with the breathing, they used to have recurrent chest infections. Their mother used to tell them that yes, आपकी पसली चलती थी बचपन में, आपको बार बार खांसी होती थी. So these are the symptoms start in the early heart, then it is more likely that he has got an asthma. Then there is a day-to-day variation. Every day, you will have sometimes, some days are good and sometimes are bad in asthma. Some seasons are very good. For instance, majority of our patients in summer feel better than in winter. So these variations so much in the symptoms is usually suggestive of asthma. Unlike COPD, there is a slow, gradual progressions of the symptoms. You can have recurrent exacerbation in COPD and sudden worsening of the symptoms, but most of the symptom gradually progresses. Even during in one day, the symptoms are worse early in the morning. As I mentioned to you, that in early part of the morning, when you are just woken up, your sympathetic system is also sleeping with you. It is not active, so you don't have a lot of catecholamine in your blood, and catecholamines are strong bronchodilators. So that's why you have narrow airways in the morning, and the symptoms usually get worse in the morning. And this is more pronounced in asthma patients. Then again, there will be history of other allergic disorders like allergic rhinitis, eczema, a family history of asthma. So this, if you have family history, then more likely that you are suffering from asthma. If you have got allergic rhinitis, if you have got allergic eczema, then you are more likely to develop, do you have asthma? But in COPD patients, usually there will be history of either smoking, use of biomass, or working in a dusty surrounding, or passively smoking, passively exposed to smoking. These are the factors which are contributory to develop COPD. So these are the differences in that. Now remember that beside pharmacotherapy, all these patients who have got established COPD, they should be receiving influenza vaccination yearly, as well as pneumococcal vaccination once in their lifetime. And finally, all patients should be encouraged to give up smoking. This is equally important. So smoking cessation is most important point, and how we usually help these patients by asking repeatedly, identify all tobacco users at every visit, whether they are still smoking or not, advise them strongly, urge them to give up smoking. Every time assess their determination. These are called 5 A's of giving up smoking. Determine their willingness to make a quit attempt, assist them, aid them, help in quitting, and arrange their recurrent follow-up once they have given up. So smoking cessation, all the medication which we have talked about may help in reducing the symptomatology, but there is only one thing